What's up, guys? Welcome to the Boss Body Podcast with Dr. Tim Jackson. Today, I have a very special guest, the director of iron-centric direct primary care, muscle-centric medicine in Florida, Mr. Stefan Hartmann.
While I make every effort to broadcast correct information, I'm also still learning. I will double check all my facts, but realize that healthcare is a constantly changing science and art. One doctor or healthcare provider may have a different way of doing things from another. I welcome any comments, suggestions, or correction of errors. I take no money from supplement or device companies. By listening to this podcast or reading this blog, you agree not to use this podcast or blog as medical advice or to treat any medical condition in either yourself or others, including but not limited to patients that you are treating. Consult your healthcare provider for any medical issues that you may be having. This entire disclaimer also applies to any guests or contributors to the podcast or the website. Under no circumstances shall any guests or contributors to the podcast or blog or any employees, associates, or affiliates of the Boss Body podcast be responsible for damages arising from use of the podcast or the blog. This blog or podcast should not be used in any legal capacity whatsoever, including but not limited to establishing the standard of care in a legal sense or as a basis for expert witness testimony. No guarantee is given regarding the accuracy of any statements or opinions made on the podcast or the blog.
Is it Stefan or Stefan?
No, Stefan. That's good.
Stefan. Awesome. So you are, you graduated, you're pretty young. You graduated in what, 2018?
Yeah.
Is it master's or doctorate now?
It's a master's PA.
Yeah. So, okay. So that's awesome. And so you lift, which is kind of unusual for PAs, right? Like, it's kind of like, oh, well, everything's a medication deficiency, right? Like, why would
Right.
you lift weights? That could kill you. So I would be interested to pick your brain because I got in trouble a lot by questioning things in my doctorate program. And, we had a lot of classes together with the PA students. And they're like, why don't you just shut up? I'm like, why do you like? We had a lecture where we were told that if we ate more than 20% of our diet as protein, we would have renal failure. And I said, if that were true, I would have been dead years ago. And my professor asked me to apologize to the guy giving the guest lecture. I said, no, you want me to apologize to him? He should be apologizing to me. So did you get in trouble in school?
Oh yeah. Yeah. I got some hot water for sure. But that's crazy. They were suggesting that uh well, I didn't have anything like that because nutrition didn't even come up in PA school. I mean, so there was
Yeah.
we get zero education in nutrition. I mean, the most is like the extreme nutritional deficiencies. Like they'll put up a picture of some kid starving in Africa and like, okay, this is rickets. Right? Like stuff like that, like really extreme stuff.
Right.
Or they're like, a patient comes into the ER, they're confused, they're irritated, they're belligerent, they're an alcoholic. What's the most likely reason? And they're like, okay, it's a B vitamin deficiency, a thiamine deficiency, like really extreme stuff, right? But in general, like nutritional optimization that prevents diseases, there's zero education in that, right? So that's the problem.
Yeah, absolutely. And then you guys rotate through because I think it's what, like 27 months. And so that's a lot to cover in 27 months.
Yeah.
But you do rotations in a lot of different specialties. When you went out and you first started practicing, what was your first job?
Well, in rotations, like, yeah, we did everything general education as a PA. So we have surgical training, and I had quite extensive surgical training in PA school. And then pediatrics, we had, family medicine, internal medicine, so hospital medicine, emergency medicine. So we rotate through the general education, and that kind of develops us well to go out into the field. So the first job out of training, I worked in an internal medicine urgent care facility. And that was great because it was a mom and pop. It was an old school physician. She was Indian, and so she did everything in house. Most doctors, primary care offices, they refer everything out, but this was different. She practiced old school, the way medicine was like 50 years ago, where they did everything in house, right? Endocrinology, cardiology, urology, like she didn't refer anything because, those money lost for her, right? Because
Right.
more patients you can see, the more often you can see them, the more money it is for you. But also, I think that's better to just keep everything in house rather than have someone see, 10 different specialists for a variety of things.
Right.
But it was allopathic medicine. So it was the standard kind of cookbook, although it was a little bit deeper, like internal medicine, how I had learned it in my hospital medicine rotations. That sort of medicine is about the closest you can get to functional medicine in an allopathic world. It's when you're sick in the hospital and you have to be seen by an internist, or if you can get a really good internist who will do, deeper testing. Sure, it's allopathic and the approach is allopathic, but the assessment is much deeper than what you could get generally.
Right. Absolutely. And so how did you come to find functional medicine?
Well, I was always going to do functional medicine, and that's how I ran into some hot water in PA school because I was thinking outside the box. My background, my parents raised me. They never brought me to a pediatrician. I never had a well child check, never got a vaccine. To this day, I've never had an antibiotic because my parents didn't treat illnesses that way. When we had an illness, when their children had illnesses, it was what did we feed the child? Did they have too much sugar? Did they have a pasteurized dairy? Did they sneak some junk food, and that's why they have an earache. That's why they're coughing. It
Right.
wasn't go to the doctor, get a pill for it. So that was my upbringing, right? Very different. It's all diet, nutrition, and exercise. And then my undergraduate is sports and exercise science, kinesiology, which many PTs like yourself go through that program before going on to PT. I think most of my classmates were going into physical therapy.
Yeah.
I was one of the few, PAs who took an exercise science undergraduate, which was phenomenal because that taught me how to, build muscle and taught me
Right.
the muscle-centric medicine approach. Because right after that, I went into training. I was a personal trainer, and I just saw how just with a bachelor's level in exercise science, I was reversing people's diseases. I mean, I had diabetics, their A1Cs were getting better. I mean, they were getting stronger. They were, their doctor was impressed. Like, well, what are you doing? You're losing weight. You're getting stronger. And this was cool to see. So with that knowledge, I approach patients working in urgent care internal medicine. And yeah, the doctor, she mostly kind of let me do that to some degree. She's like, oh, what are you talking about? Just sarcopenia. Why are you telling patients they have sarcopenia? And this is not very well known in allopathic medicine. As sarcopenia is the muscle loss with age. It's
Right.
very common. It's not diagnosed because you'd have to eat more protein and lift weights to reverse it. There's no pill for it, and most allopaths are not they're not understanding in this.
Right.
So I had that approach, and then I started learning on my own nutritional optimization and functional medicine, and just studying by myself because I was seeing these patients come through the urgent care, and I had a little bit of free reign there, so I could sit down with a patient, I could talk to them about their diet, just, oh, you're fatigued. What do you eat? Oh, you're a vegan. Oh, okay. Well, you're probably B12 deficient. You're this deficient. And I'm like, what? I eat a good diet of, corn and
Right.
vegans. Don't get me started. I'll get in trouble.
Yeah. Exactly. Yeah, so I went to undergrad at Wake Forest in North Carolina, and we're one of five programs in the US in undergrad where you get to dissect a human cadaver.
Mm,
And so I was very spoiled. I got to take gross anatomy as a pro section, but then my grades were high enough. I was a TA, so I got to dissect the cadaver before I ever finished undergrad. And I minored in chemistry. So I had a surgery the fall break or winter break of my senior year, where they broke my maxilla and my mandible. And, back then I was in the allopathic mindset. So they were like, if you don't have this surgery, you won't have any teeth left by the time you're 30. And I was 20 or 21. And so you're like, oh man, I got to have this surgery. And I got very sick from it. And now I know it was a totally unnecessary surgery, but that opened my mind to, okay, allopathic medicine is probably not the answer. And I did preceptorships at the medical school, and they said, you're definitely smart enough to go to medical school, but I don't think you're going to be very happy. Just get a ticket to play the game. I was like, what do you mean? They said, well, just get a doctorate or a master's in something in healthcare, like just a clinical doctorate. I was like, okay. And so I was going to do clinical psychology, but then I'm like, no, I like physiology and biochemistry too much. So I never really did orthopedic rehab. I did it for like a year, and that was it because I was treating a lot of subclinical hypothyroidism. Like I can manipulate your joints and mobilize your joints, but it's not going to help if you're chronically inflamed internally. You know the deal.
Yeah.
Yeah. And so I'm always interested in hearing people's backstories. But speaking of thyroid, iodine. So you're writing a paper on iodine. There's a lot of controversy around. So you probably know that I don't have it up here. Dr. Dadis Karazian, he's a chiro. Why do I still have thyroid symptoms when my lab tests are normal? And so it's a really good book. I think it was written in like 2009. But he has three doctorates, and I think he does research at Harvard. But he's a chiropractic neurologist, and he talks about some of the research on if your thyroid antibodies are elevated, TPO, antithyroid globulin antibodies, and you give iodine, it could cause an autoimmune flare.
Hmm.
But then
Yeah.
I've seen David Brownstein, some of his data, and he says, oh, no, it's an iodine deficiency. And that's
Mhm.
what's allowing the antibodies to form in the first place. So, what say you?
So if you're worried about antibodies, you want to give them selenium. It's very simple. You can give them 200 to 400 micrograms of selenium. I do it. I give plenty of people 400 micrograms of selenium. There's no problem. There's no toxicity with that. You load them with selenium, the antioxidant, for a couple weeks, maybe a couple months if you're worried about it. And then you can give them iodine. And typically you won't see a problem. Now, there's some patients and they will react to the iodine. And I have one who is doing that, and we're still trying to figure out why. Um, so far, it seems like she may have Lyme, she may have stealth infections. And I think iodine may precipitate a reaction in some people, mostly because it's an antimicrobial. What do we use iodine in for? Surgery. It cleans the skin before you make the incision. It's highly antimicrobial. So what might be happening in some of these cases is you're getting basically a Herxing reaction, a Herxheimer reaction
Yep.
when you take iodine. You're getting a fungal die-off, you're getting some stealth infection die-off, and then you react to this. And yes, it can cause inflammation. You can maybe get some acne on the skin, or something happens. So inflammation goes up. And you need to address the underlying reason why they're reacting to it too.
And a dumping of the halides, right? Fluoride, all of those,
Correct.
because they're going to displace iodine. And then you start
Correct.
repleting your iodine levels. And that could, kick off. Plus, you increase cellular ATP, you're going to start dumping toxins, right?
Yes. It's so we do the iodine challenge test here with Brownstein got me onto that. And basically you do a pre-test and determines how much iodine they excrete, a random urine iodine. And this by WHO criteria, you can look it up. You can see what deficiency is based off epidemiological data. And they use this to determine iodine deficiencies in, say, Africa. That was another one I saw a picture of in PA school. They're like, look at this. This is cretinism, right? You're not going to see this in the US. This is a short stature. This is a low IQ child, behavioral issues. That sounds like a lot of children in the US. You're not going to see this in the US because this is iodine deficiency. We put iodine in the salt. Don't worry about it. Well, this is not true. Everyone has iodine deficiency. I'm writing a paper on this because we've tested about 150 patients at the practice here, both random urine iodine, serum iodine, and the iodine challenge tests. And lo and behold, like to a rule, everyone is iodine deficient, even by WHO criteria. But then when you give them the loading test, you give them 50 milligram iodine tablet, which sounds crazy. 50 milligram, oh, that's going to kill someone. It doesn't. They're fine. You don't even notice it most of the time. And
Right.
then you see over 24 hours how much iodine is excreted. And so you say you take 50. After 24 hours, only 25 milligrams is in the urine. Where did the other 25 go? Well, you absorbed that. It went to tissues that require it. And tissues that require it, not only the thyroid, but the breast tissue for women, the prostate, the uterus, and the ovaries. All of these require iodine. And when you have low iodine, you get abnormalities, you get abnormal growths of these areas. And then through this 50 milligram process, you can also determine how many toxic halides they kick off. And lo and behold, people will kick off toxic, even by WHO criteria, toxic levels of fluoride and bromide. And these are halogens that really have no purpose in the human body other than cause disease.
Yeah, it's really interesting you brought that up because there was a Instagram thread, a guy, Andy Galpin. He's a performance scientist. And he said, oh, well, before we make America healthy again, we need to operationally define what healthy is. And I said, well, before we get into specific biomarkers, there's no physiological or biochemical role for mercury or fluoride or any of these other toxins. Like, I minored in chemistry and I never once heard this. And they're like, oh, well, you don't understand science. Do you have the data showing that fluoride is actually harmful? I said, yeah, go to PubMed, type in fluoride IQ. There's a paper out of Harvard. That was the main study, right? Showing decreased IQ. But it's amazing how people will, the saying, it's easier to fool someone than to convince them they've been fooled.
Right.
And so the biological dentist I know, they say there's no independent studies showing benefits of fluoride that have not been funded by Colgate or Crest or some of these other companies.
Amazing. Oh, that's terrible. Uh, the fluoride and the bromide, it's in a lot of things. So things that we don't think about, a couple pharmaceuticals come to mind. So if you look at ipratropium bromide, it's bromide's in the name. It's a respiratory medicine used for asthma attacks. Other common ones, fluoroquinolones. So these antibiotic drugs that do cause a bit of havoc on people. We know they now have black box label warnings for aortic dissections, tendon ruptures. So these have fluorides on them. And then a lot of the steroid medications that we use, so budesonide and the synthetic steroids, they oftentimes have fluoride atoms attached to them because they make them more potent. So they can be more useful. And so a variety of pharmaceuticals that people are taking on a daily basis, not just the toothpaste, the tap water has fluoride in it too. And then I found also these mega carbon fluoride chains that are found in the plastics. So the PFAS is in plastics. They're forever chemicals, but they're essentially super potent fluorides. And so we're inundated with these things. They're not going away. I tested my Culligan water, and it's a plastic
Oh, I think I
container.
saw that you posted on Instagram.
Yeah, and it tested positive for um, PFAS, multiple PFAS, not super high where it's be above some sort of threshold criteria, but they're microdosing of PFAS. And so I was getting like a consistent dose of PFAS for like many years because I was drinking this water. I think it's may have precipitated some of my thyroid issues as well. And then bromine, you get bromide again from certain drugs, but also Brazil nuts. And so patients will tell me, I'm going to get selenium from my Brazil nuts. Unfortunately, if you don't know the farmer, you don't know what they're spraying on the Brazil nuts. So you can spray a pesticide that contains bromide on your plants. It will kill insects. This Brazil nut is an essential mineral absorber. It's very good at absorbing minerals. Yes, selenium, if you spray selenium on your plants, but more than likely bromide and other metals.
Wow. So you mentioned fluoroquinolones. Those are huge. So I do a lot of epigenetic testing. And granted, anyone can have a reaction to fluoroquinolones, but the SOD2, superoxide dismutase 2 genetic variant, if you're suboptimal or poor, you can't protect your mitochondria. And if you have glutathione deficiencies and polymorphisms in the glutathionization pathway, then taking a fluoroquinolone could be, independent of tendon ruptures, could be life altering.
Unfortunately, there's some patients that will be affected permanently by these. And you can see them on Facebook. There's some Facebook pages. There's some YouTube videos dedicated to this. I've seen some patients with this problem. I have one whose aorta disintegrated after this. It was during the COVID pandemic. He went to the hospital for, I guess, pneumonia. They gave him an antibiotic. Didn't work because it was COVID. He came back and they gave him a stronger antibiotic, which happened to be Cipro. And in the subsequent weeks, essentially his aorta fell apart and he had to spend like 17 hours in a surgery piecing him back together with some porcine valves. And it was never linked together. I figured this out because I just asked the questions. You know, you know, that brings me back to this other subject. You ever watch, the shows like Grey's Anatomy or The Resident on Netflix? People love these shows, right?
Yeah.
And it's like this weird fantasy where, doctors actually pay more attention to you than like 30 seconds, where they go in deeper. They're trying to find the root cause. It's almost like functional medicine. And so this beautiful like fantasy that, people have. And People who want to become doctors have, and they watch these shows, they get all inspired. It's not reality in allopathic medicine. You don't spend
Right.
that level of detail trying to figure out what's wrong with someone. And I wish it were like that. It's not a reality unless you go to a functional medicine that can spend more than 5 minutes with you and think about your problem. But like that case there, I just had to ask the patient and I put it all together in this puzzle. And I'm like, okay, well, we know this problem causes this, and you got this, and you had this result. And he's like, oh, no one ever put that together for me. But no one has spent more than 5 minutes thinking about it. They're like, oh, we just fix it and you just out the door. Stuff like
Yeah.
that.
Well, and that's the thing. There's almost always a safer alternative. Well, first of all, how do you know it's bacterial? Number one, to your point, right? And I was given fluoroquinolones by the head of the ENT department at Wake Forest, which is a top 25 medical school. Now, this guy was so big, he was over 400 pounds, he could barely fit through the door. And he's like, oh, yeah, you just need some Cipro. Da, da, da. I had, a little fluid in my ear. I didn't need any antibiotic, but, I didn't know better when I was 19, right? But these things that happen, like there's almost always a safer alternative. Like if you have to use antibiotic, use one that's not a fluoroquinolone, like unless there's no other option. I mean,
Right.
I know a guy, when I was practicing in North Carolina, he was running $100 million construction company, and he was put on not one but two statins, and he had so much muscle pain and
Hmm.
myopathy and tendon issues. He was in a wheelchair. So yeah, I mean, it just seems like now you have elementary school kids on statin drugs.
I don't know any. That's crazy. Is that happening? That's real?
Yeah, yeah,
Oh my God.
yep. I know of a few.
Holy moly, that's bad. Well, the cardiologists now, they want cholesterol very low. They say there's no safe acceptable dose of cholesterol. Some are saying down to 30. They want a cholesterol level of 30.
I don't know if
Yeah.
you'd be alive.
I mean, they'll do it to themselves. They'll put their patient on it and I'll get in arguments with them on Twitter, X, and they're arguing for an ApoB level of maybe 5 or 10. They're crushing cholesterol out there because they're saying, okay, we've been wrong about cholesterol in the fact that the levels haven't been low enough, right? So that's why people are still getting heart attacks and strokes is the cholesterol isn't low enough. So there's no acceptable dose of cholesterol. We need to crush it down to as close as you can to zero. So they're using Repatha, these new disease modifying drugs to lower the cholesterol now because the statins sometimes don't even work well enough to lower it. I just think it's still barking up the wrong tree. The cardiovascular disease, yeah, it is a big problem in the US. A lot of people get it. I think it's more complicated than just cholesterol. I think in some patients, it might be warranted. Like I can think of a couple of cases at my practice where a patient had elevated genetic risk, so they had elevated lipoprotein little a. They had very high ApoB, and they had also very high lipid particle counts. They also had insulin resistance. They had high homocysteine. They had high inflammation. And yeah, this guy has coronary artery calciums. They have cardiac disease. They have strokes. Yes. So there is some people that I think need lowering of these lipids, but trying to reduce it at a population level, it hasn't panned out in the past. Like if we look at the studies like on Crestor, it's actually one of the best classes I had in PA school. It was called evidence-based medicine. And we looked at the studies of how these drugs got approved. And in this
Right.
process, we learned that the number needed to treat with Crestor is 100. So to save one patient from a heart attack stroke, you need to treat 100 patients. So on a population level, you have to treat everyone, right? And if we're now trying to move the needle down to very, very low cholesterol levels, this is probably going to result in more side effects, as we have already seen with the side effect profile of statins, just at lowering it somewhat. Now they want to crush it even lower. What are we going to see long term with that? My suspicion is hormonal disruption, because the cholesterol is the first molecule that creates all the hormones in the hormone cascade. There's cholesterol, then it's pregnenolone, and then downstream of that, all of the other hormones. So I think if we have cardiologists crushing cholesterol, they need to also be doing hormone replacement therapy, which they're not doing, of course, because they think hormones cause cancer and strokes and heart attacks, which is actually the opposite is true. They
Right.
decrease heart attacks, strokes, and cancers with proper hormone optimization. So that's my argument currently for any cholesterol zealot is, are you doing hormone replacement therapy if you're cholesterol crushing?
Yeah, I agree with all that. And so in undergrad, I worked in cardiac rehabilitation. Wake Forest was the first cardiac rehab in the southeastern US. And so I would get up at 6 a.m. Monday, Wednesday, Friday, and we were studying C-reactive protein. And it doesn't sound groundbreaking now, but back in 2001, it
Yeah.
was pretty groundbreaking.
Yeah.
But homocysteine, that's a methylation issue, right? B12 and B9 and all the Bs, but especially B12 and B9. And only about 12% of the cholesterol we eat is absorbed and shows up on blood work. So it's usually an inflammatory issue, right? Cholesterol is made by the liver to quell inflammation. It could be a stealth virus, Epstein-Barr,
Yes.
HHV6, mycoplasma,
Yes.
mold.
Yes.
I have a colleague who had a heart attack 33 from mycotoxins because
Yep.
vasoactive intestinal peptide gets lowered. You get vasoconstriction. So he had a heart attack. And his lipid panel was fine. LPA, niacin is good. There's a product called Saruta Plus from Standard Process.
Hmm.
I like Arteriasil for the
Yes.
glycocalyx. But all those things, yeah. And there's so many medications out there, and you can look at SLC01B1, solute carrier 01B1, and that's the gene that metabolizes statin. So it can tell you someone's risk for developing myopathy, side effects, etc.
Mm.
But yeah, like the commercials, at least here, for the class action lawsuits against testosterone. Oh, did your doctor prescribe testosterone replacement? Did you have a heart attack? Da, 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 da. Well, the study, they took guys who were around 250 nanograms per deciliter, gave them enough to get to 350, then several had heart attacks. And I said, see, I told you testosterone causes heart attacks. Well,
Right.
no, you got to get to at least 550, right?
Yeah. And then there's other studies that where they gave them testosterone and then they stopped it. So they did a short duration because that was the previous thinking. The old school is like you give it for the shortest duration of time and you stop it. And these guys also did worse too. So we shouldn't be doing that. We're doing hormone replacement therapy for life, for optimization, for decreasing cardiac risk, for decreasing cancer, for decreasing frailty and fractures with age. That's why we're doing hormone replacement therapy. It should be part of primary care. It's not currently. I hope it will become, but it would take a complete revamping of our medical education system because we got like zero education in hormone replacement therapy,
Yeah.
like none.
Yeah, exactly. And the thing that I keep repeating over and over, and I'm sure you do it as well, day in and day out, is people say, "Oh, my labs are normal." I'm like, "Okay, humor me. Let me see them." And
Hmm.
it's like testosterone 297, and
Hmm.
they're 35. I'm like, "That's not good. Your risk of all-cause mortality just went." And so, testosterone helps with reverse cholesterol transport, anti-inflammatory, helps the mitochondria. So all those things, cognition. Um, but yeah, I think, if you look at even the thyroid reference ranges, when the statins came on the market, so hypercholesterolemia used to be diagnostic of subclinical hypothyroidism. And
Hmm.
then the statins came on the market. And then they're like, oh, well, that won't work. So we got to change the reference ranges. And so there you go. Right.
Yeah. I like to use young teen or young adult reference ranges. So thyroid in young adults, you can see a free T3 value of 4, 4.5, even above that. Past age 30, you're lucky if your free T3 is 3. Most of the time, it's
Yeah.
below that.
Yeah.
Testosterone levels in young adults and teenagers and men, you're looking at upwards of 800, 1,100 total, free between 15 and 20 if you're using LabCorp, or much greater than that if you're using Quest. So very high. And then pregnenolone values, DHEA off the chart. You're looking at DHEA-S 500 to 600 in teenagers, pregnenolone upwards of 200 to 300. And then progesterone in young women at peak luteal phase, you're looking at progesterone around 16 to 20. You're looking at an estradiol 160 to 250. So these are the optimal ranges. This is when you're feeling your best in your youth. You're looking at IGF-1 levels. Of course, they're going to be higher the younger they are because they're growing, but optimal IGF-1 levels are between 200 and 300, ideally, right?
Yeah.
So this is what we want to use.
Absolutely. And something I learned, and this guy is actually for the most part, a conventional endocrinologist, but he taught me, he's in Atlanta. He said that if you want to get an accurate growth hormone measurement, the textbook of endocrinology and the textbook of internal medicine say 50% of people with normal IGF-1 levels, they actually have low growth hormone, but you got to do a glucagon stimulation test to see it. And my levels were low. There's something called Dennis-Robertson syndrome. When mycotoxins colonize the paranasal sinuses, they lower growth hormone. And it's not always permanent, but it can be. And so I take 1 milligram of genotropin, not an anti-aging dose, but enough just to get my levels so that I'm, recover better from workouts, sleep better. And, they can't argue with the endocrinologist. So the insurance approved it and I don't have to pay for it.
Wow.
Yeah. And so, I mean, he's very outside the box for a traditional endocrinologist. But if you go on PubMed and type in Dennis Robertson syndrome,
Yeah.
so Dennis and Robertson are both doctors in Atlanta, and
Yes.
Robertson's my doctor. And
Oh, wow. No,
that's how
I
he
know
gets
Dennis
most of it.
Robertson, the ENT. I've attended lectures with him. He does amazing like sinus cavity surgeries where he like clears out the biofilms of these fungus. Amazing stuff.
Yeah. Yep. Absolutely. And so it's basically like using your pituitary as a punching bag, because of the access points. But yeah, the genotropin, it's good stuff. And then you can use, I'm sure you use peptides in your practice.
Yeah, we use peptides. We use growth factors, develop antler. It's hard to get growth hormone. You can't get it prescribed by an endocrinologist, and you can only get it, off the internet for the most part. So I'm hoping that changes, that we can prescribe it eventually for anti-aging purposes. Currently, the regulations don't allow that. You have to have, as you said, you have to have the stimulation test to get approved, or you have to have like chronic kidney disease or something extreme to get growth hormone approved.
Yeah, well, Dennis said it to me very plainly. He's like, that was the worst thing we could name it is growth hormone. It should be called new
Right.
cell hormone because
New
without it,
cell
we're
hormone.
stuck with the same old hormone, same old organelles. And so we're
Yes.
just making new cells with the same old organelles. But
Wow.
it could be life changing, especially if you've had mold exposure. And a lot of people, they detox the mycotoxins, but they still may not feel, 100% well. And so it can be beneficial for those people for sure.
Fantastic.
What's the most common condition you see in your practice
It
today?
would be hypothyroidism. Everybody.
And that's going by free T3 at least 3.5.
Yeah. So free T3 below 3. So, under 3 free T3. This is like a subclinical hypothyroidism. The conventionalist will look at just the TSH. It misses it. The TSH will be 2 or 3 and they'll call it normal. I mean, optimal TSH is like, 0.2 to about 0.5. You don't want a super high TSH.
Right.
Unfortunately, they don't look at that. Maybe calls here. I don't know how to get these calls to stop. Anyway, here it is. Yeah, so then we also look at T4, of course, and the T4 converts to T3, but that is dependent on your reverse T3, right? So the higher the reverse T3, the lower the T4 conversion to the T3, but growth hormone will decrease reverse T3 and will improve the conversion of T4 to T3, which is amazing because then you can use growth hormone to improve that along with thyroid and thyroid medicine, iodine, and selenium to try to improve your active thyroid function. But that was a curious thing that I learned in my research on growth hormone is, wow, we have all these people with high reverse T3. You give them growth hormone, it can improve their thyroid function too.
Yeah, and do you see so estrogen dominance, you know how it can increase thyroid binding globulin? So not only does it bind to the androgen receptor, but it can slow down the thyroid. Do you see that?
So the estrogen dominance thing is interesting. I was just on a lecture last night with Dr. Ben Wantano. He's an allergist immunologist, and he was talking about the xenoestrogens and how we're exposed to a lot of these endocrine disrupting chemicals. And these are by proxy not really an estrogen dominance, but they're estrogen mimickers, and they promote allergies, they promote autoimmune, they promote obesity. But if you look at the blood work, estradiol values typically are very low, and they're getting lower and lower along with progesterone, is particularly for women. And this is driving a lot of infertility problems because women are not cycling their progesterone appropriately. Without progesterone, they cannot achieve a pregnancy and they cannot maintain a pregnancy. So more and more women are requiring to get progesterone injections to maintain their pregnancy. And then if you look at the labs mid-luteal phase, I mean, I'm seeing lower estrogen values as well in these younger women. The estrogen dominance usually happens around mid-age, about age 40 in women, where the first hormone to go away is the progesterone. So they'll still produce estrogen, estradiol, and estrone, unfortunately, especially if they're fatter, because estrone is produced from the fat cells. Estrone, unfortunately, is inflammatory and proliferative. Estradiol is anti-inflammatory and proliferative. So what that means is estradiol helps you repair cells, helps you maintain that skin elasticity. It improves arterial pliability, so you have better perfusion. But estrone is a little bit more problematic. And unfortunately, we're seeing maybe a higher estrone problem, and this can be prevented with proper progesterone production. And then getting more of these xenoestrogens, the Chanel, Dior perfumes, going to Bed Bath and Beyond, getting these chemicals, the candles, and then just the plastics we're exposed to. We're drinking the plastics, we're wearing plastics. So we're getting a lot of these estrogen mimickers, and that's the real problem. So I don't know if it's like an estrogen dominance, it's like an estrogen mimicker problem, and then a lack of hormonal balance. That's the issue.
Yeah, no, no, I agree because I've seen people where I know they're estrogen dominant for a fact, but their estradiol lab values are not what you would think they would be. So it's coming from, exogenous sources, whether it's personal care products, food, water supply, etc. Even BPA on the receipts. I tell them to put it in the bag, or I just don't get a receipt at all. Because everywhere returning, and especially, I mean, hopefully everyone listening knows not to heat plastic up in the
Mm,
microwave. If you're using the microwave, do not heat plastic up ever.
don't do it.
It's not worth the risk.
Yeah, very bad. And so this is leading to a lot of cancers, this
Yep.
problem, and an overgrowth of tissues. So we're seeing enlarging prostates, and we're seeing enlarging breast tissue in men and women, painful breasts for women, the fibrocystic breast disease, which I was recently politically corrected on by a breast surgeon. Who's interesting. He went to a steak dinner, and they're buying a steak, and they're teaching us about their fancy breast surgeries. And, I let them give their dog and pony show. I stand up, I raise my hand. It's like, okay, we know that mammograms have less utility when there's a fibrocystic breast because you can't see through it and you can miss a cancer or you can overdiagnose and you have to send for a biopsy. Everybody's panicking. So why don't we use iodine to fix fibrocystic breast disease? And the surgeon said, well, first of all, we don't call it fibrocystic breast disease anymore. And I'm like, okay, what do we call it then? She's like, well, it's just normal breast tissue. So what they've done is they've normalized a
Pathology.
pathology
Yeah.
because they don't know how to fix it. And so their solution for this is, well, you just do the MRI and if it's suspicious, you got to biopsy it. I'm like, whoa, 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 whoa. We can treat this. We can give them even topical progesterone. There's studies from the 1990s where they gave women topical 2% Lugol's iodine and they resolved their symptoms of fibrocystic breast disease. So if it can be resolved, it's still a disease. And then she's like, and I almost got an argument with this lady.
Yeah, I know it's dogma, dogma, dogma. The medical world is full of dogma, and people like you and I were like, oh, okay, well, maybe I was wrong about that. Let's revisit it. Let's hear them out. But some people just dig their heels deeper into the sand. And I have a colleague who owns some compounding pharmacies, and he had this patient come in, and their primary care doctor was out of town, and they put the daughter, who was like 8 or 9, on an antidepressant. She wasn't responding well, so he recommended omega threes and L-theanine. Fast forward 2.5, 3 weeks, she's doing really well. And she went back to see her primary care doctor, and they told him what the pharmacist said. So then they send the state board in to investigate. Now they're undercover, but they said, "Oh, excuse me, can this product cure?" So that was a red flag. Like, obviously, no, no, nothing cures. You can't diagnose, treat, or cure or prevent. It's just food related supplements, food derived supplements. But I'm thinking this doctor would rather have his ego boosted and the little girl suffer than the little girl feeling better and learn something. And that's really
Wow,
unfortunate.
that's unfortunate. That's crazy.
Yeah.
It's it's always going to be someone else who reports you. That's what someone told me once. Someone, one
Yep.
of your colleagues.
Yep. Yeah, exactly. I've had several colleagues get reported that way. And usually, like, I don't know if you heard about this. This was in Texas. It was a husband and wife, and the wife was an ENT, and she was losing patients to someone across town who was doing more functional medicine. And he was filing these anonymous complaints to the medical board. And I don't know how they found out, but needless to say, he got in trouble. But yeah, that they were filing complaints because they were losing patients because they were resolving the patient's issues. It's super
Yeah,
unfortunate.
I could see that happening totally. I mean, we resolve patients' issues here. I mean, there's no doubt about it. I mean, we reverse conditions that are not treatable all the time. Like I had one case today. I had a lady, and she was getting older, 60s. She's having incontinence. You know, this is a common problem that women get. I mean, sure, you can, as you know, you can do physical therapy for this, but I prescribed her intravaginal suppositories of hormone replacement therapy, and we fixed this. She can ride her horses again. She's back to her life. No incontinence anymore.
That's awesome.
Yeah, I mean, hormones are can fix a lot of problems. We have a lot of
Yeah.
cases.
And you guys have a biohacking center attached to your clinic?
Yes, we do. We have what I call the Human Performance Arena. It's a fun
Because you have a
project.
Morosco, right?
We have the Morasco Cold Forge. Yes.
Because I had Dr. Tom Seeger on.
Oh, you had Ziegler. Oh, he's a
Yeah.
hoot. I love him.
He has the deepest voice. I swear. His testosterone must be like 3,000.
It is. It's at about 1,200, and he says the cold has helped him.
Yeah. Yeah. He told the story on the podcast where now he does the cold plunge, then he works out versus working out
Right.
and doing the cold plunge.
Yes, I that's my protocol over here, not only for sanitary purposes, because I don't want people sweaty getting into my cold forge, but
Right.
you don't want to cool off the muscle. So muscle is grown from inflammation, and it's a good inflammation. We would never want to cut off that inflammation through taking an ibuprofen or getting into a cold bath, because it can stop potentially that inflammatory process that causes the muscle to grow. So our protocol here is cold forge, workouts, and then they typically do a sauna at the end.
Yeah. And that alteration of heat and cold is great for growth hormone production, right?
Yes, the sauna apparently will increase growth hormone, the IGF-1, at about 280 degrees Fahrenheit after about 7 minutes.
Well, how high does your sauna go?
It goes to 240.
Okay, wow. Mine,
Yeah.
I have a TheraSage portable sauna where your head sticks out and it goes to 170. I didn't know they went as high as 240.
No, we have a traditional Finnish sauna, so they go very
Okay.
hot. You got to wear a Russian sauna cap, this wool cap to protect your head. As the heat rises, you can lose some hair follicles if you go, beyond 190. Usually, when no one goes beyond 190, it's pretty uncomfortable.
Yeah, absolutely. And what other kind of gadgets do you guys have in there?
We have an EWAT system. It's an exercise with oxygen therapy. So it's more convenient than getting in a hyperbaric chamber. So you can still deliver high oxygen to people. And we've
Mhm.
noticed a similar efficacy to the HBOT, where people with low oxygen conditions, so long COVID, or maybe they have poor perfusion from like insulin resistance or neuropathies, you just give them high oxygen and they perk up again. They come back, they feel better, like, whoa. And so some need it regularly on almost daily basis. I had one guy, he came the other day. He's like, I couldn't focus at work. So I come here, I get into the cold plunge and I get on the bike and I feel like I can go back and work again. So it
Yeah.
gives him a little
You
kick.
guys, yeah, that's awesome. And then you get the dopamine from the cold plunge and
Yeah.
250% rise, right?
Oh, I mean, the cold plunge has been the best thing I've ever found for pain management. And this is coming from working in spine surgery and pain management, interventional pain management and pharmaceutical pain management. And this thing takes away people's pain. They get into the cold plunge, arthritis melts away, acute pain, chronic pain, back pain, titanium hip pain, you name it, it melts away. So uh, it's effective, safe. We love it.
And if someone has like a baclofen pump, they can't get in, correct?
Baclofen? No, I never had one like that. Like they have a pump for medicine.
Yeah.
Uh, I don't know. We haven't encountered that yet. We've had internal hardware. They've done okay.
Yeah. That's what I thought. And I would think that, if you sauna, so I mean, you think about most of the things we use, light, temperature alterations, because it's cell molecular biology. There's only two ways to change the function of a protein: change the temperature, cold plunge sauna, change the pH. And I go back to that all the time. People are like, what's the most beneficial class you ever took? Gross anatomy. I'm like, no, no, no. It's cell molecular biology. And my professor, actually, he was in an MD program and he dropped out and they wanted to send him to a psychiatrist. And he's like, why? I'm not depressed. They said, well, you're one of the top students. He's like, I know, but you guys keep wanting to just hand out drugs, but it all goes back to the organelles in the cell. And he's right. He's absolutely correct.
Yeah, medicine needs to go back to the pathophysiology, needs to go back to the mechanism of action. And that's where we're going to find the pure science. These double-blind randomized control studies, they've been manipulated by big pharma to get an intended result. So that's the problem we
Right.
have.
Yeah, and they have the luxury of they do 20 studies and 19 are negative results. They can only tell you about the one. And then
Right.
people, like during the thing that happened the past 4 years, they would tell you the relative risk reduction, not the absolute risk reduction. So it was
Yep.
deceiving at best.
It's all deceiving. And we're learning that a lot of medicine is this. And when you sometimes repeat these studies, you don't see the same benefits. There's a lot of, especially in orthopedics, you've probably seen these studies where they did the sham study on the hips and or the back surgeries. I mean, I think a lot of that is dependent on the skill of the surgeon. But then I think a lot of these problems, they could be improved with, physical therapy and hormone replacement therapy. I think you can get a lot of musculoskeletal benefit with those two.
Absolutely. But then, you can't charge $100,000 for surgery. So, you know,
Yeah, but you can avoid a lot of pain and suffering and botched surgeries if you just do the basics: hormones, nutrition, movement. That's it.
yep, that's it. What's something you know today that you wish you would have known when you first got out of school?
Um, well, it would have helped to know before going into PE school that I wasn't gonna, change any minds there. I should have just been a little bit more quiet. I could just stuck my head down and just nodded along. Okay, yeah, we'll vaccinate the children. We'll prescribe them fluoride tablets. No problem. Like, yes, sir. I should have just done that, but I had to try to, prove myself there. So that it gave me a lot of hard time. But then afterwards, I kind of continued that critical thinking and questioning, and it oftentimes was at the at the cost of my career advancement in some places. Yeah, I had to go through a lot of different places, but everything like brought me to where I am here. Like they weren't even failures, but they were. I saw them as negatives at the time, but they were really just positives to bring me to where I am here today. I think going back, if I had known that you're going to have a lot of resistance, but it will all lead you to the right path, that would have been helpful. But you don't always know that.
You're either winning or you're learning, right? There's no such thing as losing. Well, awesome. Thank
I
you
like
so
that.
much for your time. Where can people find you? We're going to put the links up, but quickly, where can people find you?
Well, you have to search for me. I'm pretty shadow banned, so you can find me at Iron Direct Primary Care on Instagram. There's a backup page that people always find. It's Iron Direct Primary Care too. That's not my main account. I don't use that very much. And then I'm on X at Iron DPC. I'm on YouTube, but I'm heavily shadow banned and have two strikes against my account there. It's Iron Direct Primary Care. So I'm uploading a lot of my content to Rumble now, same name. Yeah, so
Okay.
you can find me there.
Awesome. Well, thank you so much for your time. Keep up the great work and keep saving lives.
All right.
Thank
Thank
you
you.
so much. Have a blessed day.
Will do.